morning, one and all.
But Sagar, before you start your talk, I just like to share a few of my thoughts and feelings that occurred to me this morning. It's such a wonderful topic, such a new and under-recognized topic of primary immunodeficiency, which I'm sure we all understand that if we recognize this condition and take care of this early, we are saving the life of so many of these children. And I must admit here that it's an embarrassment to the organizers, that faculty who have put in such a lot of effort in putting this talk together. We have Dr. Amit, who's traveled all the way from the northern part of India, Sagar, and Sagar, who has kept aside all his other activities of the Sunday, and he's with us. And their enthusiasm for talking to us about this topic is really, I think, we feel let down by the response of our own people, the pathologists. I really don't know where, and I'm sad about this. I really don't know where we have a problem, where this malady is, and something which I want to reach out to all our policymakers of the executive, the teachers and the students. Where are we lacking? Where are we lacking in trying to show enthusiasm in picking up and coming and attending and listening to people who have done such wonderful work? So I apologize on behalf of the organizers, Sagar and Amit, but I'm sure you put all these aside and give it your best. Thank you.
Good morning, one and all. To begin with, sir, I would say there is actually no need to apologize, because in the morning we were discussing, obviously it's difficult for a Sunday morning to get up and come, but more importantly we realize that those who have joined are really interested. So that's the positive side of it. And I have to share the thing that when I came back to Bangalore last year, I have been trained at PGI Chandigarh, both my MD and DM in pediatric immunology. And when I came back to Bangalore, the very first challenge was obviously increasing the awareness in the doctors. But the more important challenge was, even if there was awareness, there was not a proper lab who could do the complete gamut of tests. And what we very well know is immunology is and immune deficiency is such a group of disorders wherein without a lab backup, you are going to go nowhere. I can shout that this is an immune deficiency, but if somebody is not going to give the test to me, nobody is going to believe me. And that is where I have to be very thankful to Dr. Sujay, Dr. Preeti, Dr. Jairam and entire Anand Lab network here, because it has really taken it as a challenge, I would say. Because these group of tests, in the beginning, there may not be many doctors who would be looking at, and naturally for any lab, the first question is, are we going to get samples? But when I spoke to Dr. Sujay and Dr. Preeti in the beginning, they said, that does not matter. If it adds value to our services and if it is going to benefit the patients, within a year or so, we have, as Dr. Preeti said, more than 30. In fact, I would show you more than 50 cases of primary immunodeficiency diagnosed. And some of these children have received transplants. So we are making a difference. And that is where I think the entire gathering here, each one of you is going to make a difference to life. So I would like to make this session a little more interactive. I'm sure whenever somebody hears of an immune deficiency, the first thing is you get scared. Oh, this man is going to talk about T cell, B cell, those cells which even those Robbins pathology didn't like to read the 5th chapter. I want to tell you, this is clinical immunology, and I have heard people after my talk saying we need not be pediatricians, even general physicians and non-pediatricians can diagnose these conditions. So let's have some clinical insights on to primary immunodeficiency. So if there are any questions, I would like you to stop me, because this topic is not straightforward, but let's make it simple. Now, I always speak of this foundation, that's Jeffrey Modell Foundation, when I talk on this topic. This is a foundation based out in New York, which has done a lot of work on primary immunodeficiency, and that's why. Because you can see in the picture there is Jeffrey there. He's born somewhere in 1980s. Unfortunately, he started developing infections, one pneumonia, followed by the second, followed by the third. And it took them several years for the parents, the Fred and Vicky Modell, to get him diagnosed of an immune deficiency. He had no immunoglobulins in his body. Now believe me, this is New York. And if it can take years to diagnose a condition in New York, what could be our situation, you can realize. And then finally when he was diagnosed, unfortunately because of the late diagnosis, he died somewhere at the age of 16. And in his memory, the parents left everything and established this foundation. And they have been doing phenomenal work across the globe. And as per their estimate, primary immune deficiency is as common as somewhere 1 in 2000. Now imagine, I just tried to extrapolate this figure to the city of Bangalore, and I realized there should be at least 5,000 children suffering of a primary immune deficiency only in Bangalore. The actual number diagnosed may not even reach 100. That means they are grossly underdiagnosed. Now, why are they underdiagnosed? Do these children come with something very, very unusual? Let's see. When do you suspect primary immune deficiency? Now, these are the warning signs laid down by the foundation to increase the awareness in the community. Now, please look at those warning signs. If I would say repeated ear infections within a year, repeated sinus infections, I am sure even if there are no clinicians in the gathering, if there are pathologists or if there are doctors in the gathering, you would realize having repeated ear infections or repeated sinus infections means there is something wrong. But how many of us think of an immune deficiency in that setting? 2 or more, or repeated requirement of antibiotics, repeated episodes of pneumonia, or especially if an infant is not growing well and is having infections. I think all these cases warrant an evaluation. Recurrent deep-seated abscesses. For example, I am sure in the gathering there are people who have reported on pus of a liver abscess. Am I right? And you have done sometimes histopathological studies. So, if there was an abscess in a deep-seated site, how many did you report back saying, is there a primary immune deficiency in this child? The lab can make a difference. In the same way, if a child is having repeated candidiasis, means there is something wrong in his immune system. And if there is a family history of an immune deficiency. Now tell me, what kind of families would come to our setup and say, listen doctor, last child had an immune deficiency, can you diagnose this child? Is that something that you're going to see in your practice? No. The story would be, last child died of malnutrition, second child they said there was some infection and he died, we could not save him, and this is the child, doctor, can you save him? It all means that these are genetic disorders, and some of them can be so severe that they would die in their infancy. That means whenever you have a family history of sibling deaths, you need to think of an immune deficiency. So, this is the classification, and I would not go further, but this is a broad classification as to whenever you see a child with or an adult with suspected immune deficiency, I would like to put them into these 4 larger groups, the B cell, the combined defect, the phagocytic defect, and the complement deficiency. And there are a large number of diseases under each category, but let's not get confused there. Now let's go clinically, and I will ask you a few questions. What is unusual? Or if there are clinicians in the gathering, they should tell me, have they not seen such a child? Is a 4-year-old boy, comes to us with 3rd episode of pneumonia. He is being hospitalized every time with an infection, takes antibiotics, gets better, again gets admitted, and 2 episodes of ear discharge. And see the chest x-ray, I think you all know that there is pneumonia. Now, if there are pediatricians, we have always been trained. Recurrent pneumonia means left to right heart shunts, the ventricular septal defects, aspiration syndromes, cystic fibrosis, such a favorite for all of us, I'm sure, and then anatomical lung defects. Then there are CT scans done to find out if this child has got a lung anomaly which can cause a recurrent pneumonia. But interestingly, this child, when he was seen by our very resident, he was very thrilled because he's a 4-year-old boy. He wanted to see large tonsils. You know that this 2 to 8 years of age group, the tonsils are very large, and then here the tonsils are completely missing. And this is a straightforward diagnosis of X-linked agammaglobulinemia. You see the name, it is X-linked agammaglobulinemia. So what do you look at? The immunoglobulins. And when I say immunoglobulins, the IgG, IgA, IgM, all of them were missing. And which cells produce immunoglobulins in our body? The B cells. And when B cell count was done, it was like absent, and you confirm the diagnosis of X-linked agammaglobulinemia. So the simple thing was sending a immunoglobulin profile. That's what made the difference. Now this 3.5-year-old boy was hospitalized twice in some hospital in Bangalore, first at the age of 1 with fever, encephalopathy, hypotensive shock. He was on the ventilator for almost a week, but nothing was working out. And as a desperate situation, what did the pediatricians do? They gave him a dose of intravenous immunoglobulin, and that was only out of desperation, and the boy recovered. Unfortunately, 6 months later, the boy again got hospitalized with an episode of pneumonia, got better, and then when this time he got hospitalized at Aster, he had high-grade fever and the cell counts were low. I distinctly remember my colleague pediatrician called me up somewhere at around 10 o'clock in the night and said, see, there is something wrong. Why is this boy coming to me the third time? That's my question. I think, and that is where this suspicion got us to this immunoglobulins, and you can see immunoglobulins absent, B cells absent, and you know the diagnosis, it's X-linked agammaglobulinemia. Now, since these children are not producing immunoglobulins right from birth, they need immunoglobulin substitution, which is to be done every month, unfortunately, for life. But this child was started on IVIG and is currently doing perfectly okay and comes every month to get the injection shot. And that's the mutation. So, what is X-linked agammaglobulinemia? This is the prototype of a B cell disorder. Children will not come to you in months because that the mother's maternally transmitted transplacental IgG will protect them in first few months. But thereafter, after 6 months, they start presenting to you with infections. If there are no tonsils, is a boy with recurrent infections, you have almost made the diagnosis. Now, if people feel it's all restricted to children, this can immunodeficiency is present to adult physicians. Now, this is a gentleman, 41-year-old from Gujarat. He was unwell from the age of 15, almost 20 hospitalizations so far. Every time he would have a chest infection, he would go to a respiratory physician, they would do a bronchoscopy, he would be treated, gets better, again gets unwell. And then he has an episode of diarrhea, he goes to the gastroenterologist, endoscopy is done, again gets better, but no answer. Now this man was frustrated, obviously you can understand. What will he do? What do people do if they don't have an answer these days? If doctor is not giving an answer, there is one person who gives an answer, and that's Google. So he did a Google search and he was wise enough to understand if I'm having infection so many places, I'm having an immune defect or something wrong in the immune system. A second Google search, one of the best places, or I would say perhaps the best place to investigate would be PGI Chandigarh. And he just walks in our OPD, and I'm sure this was Professor Singh who was saying this child, my professor who trained me for this immune deficiency. And the man walks in his OPD and says, I have an immune deficiency, doctor. I know that. I am not traveled here from Gujarat to tell you that I have an immune deficiency. I know that. You tell me what it is and how I'm going to get treated. And then my boss calls me and he says, Sagar, come here. Look at the reports. I said, okay, sir, it will take some time. There were a few kgs. He says, no, don't look at reports. This report is more than a kg. Keep it aside. That's an immune deficiency. That means when your patients carry huge reports, you need not look at the reports. It will be an immune deficiency. That's the thumb rule. Now, what did we do? We got an immunoglobulin, and you can see again the immunoglobulins were low. But this time, the B cell count was 10%, and as Dr. Preeti rightly presented in very first talk, that I would say 10 to 15 or 10 to 20% of B cell count is a fairly normal count. That means you are seeing the condition wherein the B cells are present, but the immunoglobulins are low. That means the B cells are probably not functional. But the count is there, the number is not there, and that condition is called common variable immune deficiency. And you could see that the name says that this is a common immune deficiency. It's the commonest symptomatic immune deficiency in adults, and the presentation can be quite variable. Now, these patients usually present in second and third decade. That means most often they are going to go to adult physicians, gastroenterologists, pulmonologists, and not to pediatricians. And if I talk to pulmonologists or gastroenterologists about immune deficiencies, they may laugh at me. But that's a living case. And then these patients go around for years. Now, this is a lady, 25-year-old, who was unwell from the age of 9, repeated chest infection. She had arthritis, so she had gone to rheumatologists, orthopedicians, and then she had ear discharge as well. When she came to us, she was grossly emaciated. Somebody thought it could be HIV. That was negative, obviously. And you looked at the chest X-ray, there was bronchiectasis. So somebody thought, should we do a lung surgery? But before that, the pulmonologist called up and then said, immunoglobulin profile, and you can see everything low. That was common variable immune deficiency. What's the message? Unexplained bronchiectasis must be tested. I'm sure, again, as even if you work in the labs, you come across cases with bronchiectasis who have been asked you for evaluation. Write a note, say send immunoglobulins, and you may make a difference to that child or that patient. So if you suspect an immune deficiency, what we need is an immunoglobulin profile. If the immunoglobulins are low, look at the B cell count. The B cells are absent, most often it's going to be an X-linked agammaglobulinemia, and if the B cells present, likely common variable immune deficiency. 2 simple tests and you can make a big difference. And then these diseases are diagnosed. A 3-year-old boy from Bangalore who was ventilated at the age of 6 months in some hospital in Whitefield for almost 17 days. Severe pneumonia, ARDS, stayed there for a month. I would say the team did a fantastic job. The child got out, but then again at the age of 1.5 got an episode of pneumonia, and subsequently he would get fever and was like going on as a hyperreactive airway disease. And then when his fever did not settle for a month, here he was referred. And when I went through his records, you could see distinctly at the age of 6 months and at the age of 18 months when he was hospitalized, the neutrophil count went as low as 200, 990. That means there was multiple episodes of neutropenia. Neutropenia is fine, you do when you have infections, but why neutropenia? We got an immunoglobulins, and you can see now that the IgG is low, A is low, but the M is very high, and that condition is called the hyper IgM syndrome. The name itself speaks for it, that the IgM is high and the other immunoglobulins are low. What is it? We know that whenever we get an infection, say a typhoid infection, the first response we get is an IgM response. Few weeks later, you start getting a IgG response. We all have seen that. That is because a normal T cell, B cell talk in the body results in formation of IgM, and a few weeks later, a formation of other immunoglobulins. And this is what is known as class switch. And if there is a defect in this class switch, you are naturally going to get only IgM and not other immunoglobulins. And that's hyper IgM syndrome. But again, a simple immunoglobulins gives you an answer. A 7-month-old girl child from Bangalore comes with an ear discharge at the age of 4 months, pneumonia and thrush. I think the first thing, if a clinician is seeing this child, will think of a HIV infection because there is thrush, he is not thriving well, but HIV was negative. And then when we looked at the chest X-ray, you all see that there is pneumonia. But what's important? The thymic shadow is missing. This is just a 4-month baby where the thymus is very prominent otherwise. And when we looked at the counts, we all see at the neutrophil count usually because we are interested to diagnose sepsis. But look at the lymphocyte. The absolute lymphocyte count was only 1200. Any lymphocyte count in infants which is less than 3000, this lymphopenia means one diagnosis, and that is severe combined immunodeficiency. And I think Dr. Preeti has aptly highlighted that your CBCs are going to give a lot of clue. So if you come across cases wherein lymphopenia is persistent, especially in infants, you know it's severe combined immunodeficiency. These are young children. Because they don't survive without a transplant, there is chance that many children may have died in the family, and this is the index case you can help. And then what you need is suspicion, a close look at the differential counts and the chest radiograph, and subsequently the T cell count, and if it is low, you have confirmed the diagnosis. Now this is an interesting case. A 4.5-month-old baby comes to you with the first episode of pneumonia, is thriving well. The pediatrician just calls me up and says, "Doctor, this is likely to be an immune deficiency." I was surprised. I tell, "What's wrong? This child is doing fine. I don't ask you to investigate for the first episode of pneumonia for an immune deficiency." He says, "Last year, elder brother at the age of 6 months died in my hospital. He stayed almost for 25 days and we were not able to get an answer. Could you help this child?" And that suspicion really helped. When we worked up, this child was in fact severe combined immune deficiency. And since he came early without very severe infection, you could see we could counsel the mother, and she was ready to become the donor for this child, and this child was transplanted. So these children require a bone marrow transplant, and happy to share the picture of Dr. Stalin, who in our hospital does these transplants, and this child is now doing fine. Now this is another subset. A 4-year-old boy comes with this patch on the chest. For almost 4 weeks, we tried antibiotics. It was not resolving. And then what we did was got a lung aspirate, and what we found to our surprise was aspergillus. You know, the moment you see such an odd infection, you know there is something wrong. So we went ahead and did an immunoglobulins. You could see that the IgG this time is not low. In fact, IgG is 1860, which is much higher than the given range. So do all immunodeficiencies have low immunoglobulins? Or if there is a high IgG, should I exclude an immune deficiency? The answer is no. If you have high IgG, think of chronic granulomatous disease. High IgG can point towards an immune deficiency. And now what is chronic granulomatous disease? Again has been discussed. A neutrophil normally phagocytoses a bug and then kills it. And that intracellular killing requires an ADPH oxidase. And that is absent in them. And that is where you do this NBT dye reduction test. Again, very well explained by the previous speaker. And you can see the dye is not there in the patient where it was there in the control. And we confirm chronic granulomatous disease. So next time when you get a patient sample for aspergillus, look at the neutrophil count. You all know that febrile neutropenia post-chemotherapy is a risk factor for developing aspergillus. I am talking of a condition wherein the neutrophil count is high and still there is aspergillus. That's chronic granulomatous disease. In fact, whenever you see aspergillus, serratia, burkholderia, pseudomonas, such kind of odd pathogens, one should think of an immune deficiency, likely a chronic granulomatous disease. And if Staphylococcus aureus is troubling the child again and again, it can be chronic granulomatous disease. Again, having these bugs being diagnosed in the lab, if you can put a comment that can it be an immune deficiency or clinically correlate query immune deficiency, the clinician's antenna may go up. A 4-year-old boy comes with repeated episode of pneumonia. One episode of pneumonia was actually followed by rib osteomyelitis, and the rib was aspirated by the surgeon and he found granuloma. Now tell me, in India, if you get granuloma, what's your response? ATT, antitubercular therapy. But before this child came to us, he's not received it once, twice, almost 3 times antitubercular therapy was given. And when he came, there was a big swelling of the cervical spine. We got an MRI and we could see that there was vertebral osteomyelitis. And since these infections were going on, we knew there is something wrong. Workup showed NBT being abnormal. That's chronic granulomatous disease. So what is the message? Every time you see a child or a patient with TB and is not behaving like TB, it may not be TB. It can be chronic granulomatous disease. Second, we all know that all granulomas are not tuberculosis. But do we think if there is a granuloma, could it be chronic granulomatous disease? Now the name itself says chronic granulomatous disease. That means this disease is characterized by non-caveating granulomas. So next time you see a granuloma on your histopath slides, go back to the clinical history. Can it be immune deficiency? Can it be chronic granulomatous disease? In fact, there are scores of immune deficiency which can present granuloma, but at least we can think of chronic granulomatous disease. So these patients will come to us with repeated suppurative lymphadenitis, sometimes lung abscess, liver abscess, non-resolved pneumonia. So how many of us have really worked up lung abscess and liver abscesses for a CGD? But all of us have seen such patients or worked up such patients. They may be primary immune deficiency, they may be CGDs. Now this 3-year-old boy comes to us with pneumonia and we can see that there is thrombocytopenia. The knee-jerk reaction which most of us have, or in fact when I saw this child first time I thought this is sepsis. The child looks sick and this thrombocytopenia may be because of septicemia. But the mother said an elder boy at the age of 7 months died and he had some blood in motions. Now that was very odd. Having a dysentery-like illness and dying is very odd. We re-looked into the CBC and now you see that the mean platelet volume was very low. That was microthrombocytopenia. And as has been already highlighted, I would say, if I'm right, in medicine there is no differential diagnosis for microthrombocytopenia. It's Wiskott-Aldrich syndrome. In every child with persistent thrombocytopenia, we must look at mean platelet volume. And especially if he is a boy coming with infections and the mean platelet volume is low, you know it's likely to be Wiskott-Aldrich syndrome. Now this is a 3-month-old girl, comes with a distended abdomen. The umbilicus looks quite erythematous and you could see that there is a big perianal ulcer but not a drop of pus. First time when we saw this child, we were not sure what we were dealing with, but the mother had something interesting to share, that the umbilical cord had not fallen for almost a month. You know, normally the cord falls off by day 7, day 10 in neonates. Looked at the CBC, you could see that the counts were very high. Somebody thought it could be ongoing septicemia. But come on, this is for last 2 months, these are the counts. And the neutrophil count is as high as 60,000, 70,000. So this condition is simply leukocyte adhesion deficiency. See, it's very simple. The leukocytes cannot adhere to the endothelium. If leukocytes cannot adhere to the endothelium, they can't reach the tissue. And we all know that the pus is formed only when neutrophils reach the tissue. Now, since neutrophils are not reaching the tissue, there is no way these patients can form pus. But because there are no neutrophils in the tissue, they can't fight infections. And where are the neutrophils? They are all in the bloodstream. And that is why 70,000, 60,000, that kind of neutrophilia you're going to get. But where did the clue come from? Did we do any high-end testing? It was a simple CBC, which all have done. But if we had looked at it from the angle of an immune deficiency, that was shouting that this is leukocyte adhesion deficiency. And I think this is the last case. That is a 6-month-old child. He is actually from Kochi. This child actually came with fever and there was a rash over the body. We were not sure, but when we looked at the BCG site, this was how it looked like. A big BCG scar, or I would say in fact an ulcer. And this child actually had hepatosplenomegaly and there were large nodes, lymph nodes. So one of the lymph node was aspirated and the culture showed a BCG strain. That means this is a disseminated BCG. We all know that sometimes when children receive BCG, there is a localized adenitis, that is fine. But when there is a dissemination of BCG, that is abnormal. That means there is something wrong in the immune system. disseminated BCG, or if there is an atypical mycobacterial infection, especially when you see a non-tubercle mycobacteria, you need to think whether it can be HIV, a severe combined immune deficiency, a chronic granulomatous disease, or a group of disorders called Mendelian susceptibility to mycobacterial disease. The name suggests here there is undue susceptibility to mycobacterial infection, especially atypical mycobacteria or BCG. What do? We ruled out the previous conditions, a genetic testing, and that's the STAT1 deficiency, confirming the diagnosis of MSMD. So, seniors, colleagues, friends, we know that from our medical days we have been taught by our teachers, think common in your rounds. When you hear of hoofbeats, you are always told of think of horses. But this is what this word of PID states. When you hear of hoofbeats, you can think of zebras also. They are there. So, because zebras are like, these PIDs are like the zebras of the medical world. And in fact, this is the logo. Think zebra is the logo of Boyle, the lady in the center. And you can see in the picture that is Professor Singh, Professor Sujit Singh, who is currently the HOD of pediatrics at PGI Chandigarh, and he is the person who is actually instrumental in training all of us for immune deficiencies. And in the picture you can see Dr. Amit to speak after me, again a phenomenal person in the lab diagnostics part of it, and I've got my lab training under him. And right now I'm placed at Aster CMI with a big team of pediatrics, a lovely team, because if you have to do little complex work, you know you need help of every other specialty, and I'm blessed with that. And I could say in the last 16 months we have had almost 53 cases of primary immune deficiency. Again, thanks to Anand Lab, because most of these cases were worked up here. And if you see this number, that means every month we can diagnose 3 cases. I don't think they are rare. They are always there. Thank you.
Thank you, Dr. Sagar. And Dr. Sagar has finished his talk before this